I'm very happy to introduce Professor Erica Wood tonight for our presentation on transfusion medicine. Just a quick introduction of who she is for those who don't know. So Professor Erica Wood is the president of the International Society of Blood Transfusions and a member of the World Health Organization Expert Advisory Panel into Transfusion Medicine. She is also an NHMRC Research Fellow and the head of a transfusion research unit at the Department of Epidemiology and Preventative Medicine at Monash University. And she's also the past president of the International Haemovigilance Network and of the Australian and New Zealand Society of Blood Transfusion, and has served as chief examiner in haematology for the Royal College of Pathologists in Australasia. She's also a consultant haematologist at Monash Health and holds an honorary appointment at Peter MacCallum Cancer Centre. Thanks, Erica, so much for coming tonight. Please take it away.
Thanks very much, Gabriel. Great to see so many people here and interested in haematology and transfusion. I'll share my screen if that's okay, and then speak for, I think you said like 45, 50 minutes, and happy to take questions at the end. Like most people who are passionate about their subject, there's probably too much material, so we'll go through it quickly, but if need be, happy to cover it in the chat or people can follow up afterwards. So I'll just share my screen now. Right. Can everyone see that? Am I on the screen? Okay.
Yep, I can see it.
Okay, well, firstly, thank you for the introduction and the invitation to be here. It's really a great pleasure. Transfusion medicine is one of those fantastic fields of medicine that covers really everything, from molecular genetics to population health and everything in between. And it's really fascinating, and you need to understand at least some basic parts of it so that you can take care of your patients in the future, but also the science and medicine of it is really, really interesting. And if you have any questions for me, as I said, happy to take them tonight or subsequently. So I'm a haematologist, as I mentioned, and blood transfusion is one of the most common interventions that you will see in your practice as medical students and doctors. In Australia, we collect in the order of 1.5 million donations of different types every year to the Red Cross, formerly known as the Red Cross Blood Service, now known as Red Cross Lifeblood. And we have an important responsibility in the health field to take care of these gifts from blood donors who are volunteers. So we have a strong stewardship responsibility for these precious products, but also because, as I've put here at the bottom, we spend as taxpayers more than $1 billion a year just in provision of blood products to the community. A bit more than half of that is on the Red Cross budget for collecting, testing, logistics, etc., managing the donors. A lot of that is also for immunoglobulins made from donated plasma. And we know that blood can save lives, and we'll talk a bit about that, but it also carries real risks, even if many of those risks are now small. Something with my screen. There we go. Sorry about that. So for those of you who might be interested, this was a nice review paper published last year looking at improvements in the safety of the blood supply from an infectious diseases focus. Now, I should include the caveat that this is written really mostly from a North American perspective, and the rates of infectious diseases in the population there and in the blood donor population are different, but it really has a very nice overview and review of the current situation by several experts in the field. And in this graphic, you can see in the top section, this is a logarithmic scale looking over time. The axis is along the very bottom at Is that me or someone else drawing on the screen? Isn't that weird? Looking at the very great reduction in risk in hepatitis B, hepatitis C, and HIV over decades since the 1980s till now. And as I mentioned, it's a logarithmic scale, so it's almost hard to believe, firstly, how risky blood transfusions were in the 1980s, but also how safe they are. And things are probably much safer even in Australia. You can see here, also in the middle frame, some of the testing that's been introduced in blood supplies, not just in North America, but here and internationally, looking at different types of antibody tests, antigen tests, combination tests, nucleic acid tests, and bacterial detection of platelets and when they were introduced. But you can also see that every time one of these tests is introduced, it increases the cost to the community of the blood that's available. And this is a nominal cost related to red cells, a production of red cells. The costs are somewhat different in Australia because our health system is structured a bit differently, but they give you an idea of the vast costs involved. So with that as a bit of background and to explain why we've been so focused on infectious diseases and the blood supply, in more recent years, we've really focused our attention more on the patient who might need a blood transfusion and how we practice it in a clinical sense. So in the era of patient-centered care, transfusion has moved from often being something that was done to people without much involvement except some kind of signed consent form, to patients being more involved in decisions around potential transfusion support. We focused a lot more effort on the oversight of our practice. So having governance committees such as hospital transfusion committees, having policies and standards in place and guidelines to help us make decisions. We'll talk more about haemovigilance this evening, including and particularly non-infectious hazards with a focus on human factors. So how people like us, ordinary but educated people trying to do our best in a busy job can make mistakes, and how the environment of the system in which we work may be conducive to process errors. I guess we think now that making decisions about transfusion practice and practicing transfusion medicine is about patient blood management. So putting the patient at the center and then managing the situation around how they find themselves to make sure that we can provide something that is personalized and for what they individually need. And so I think instead of a approach where we might have in the past said, look, when would we give a unit of red cells and what's the indication for a transfusion of a product, we're a bit more focused now on what does this patient need, why, and when. So like many things in medicine, we could summarize good clinical transfusion practice as saying that this is about the right blood to the right patient at the right time and for the right reason. And that might seem like really obvious, I'm sure it is. But transfusion medicine is extremely simple, except when it's not and things go wrong. So I think one of the messages that I'd like to share with you today, especially when you're a medical student or a young doctor, is that transfusion can often feel a bit like black magic. You don't really understand it. You think you should be able to, not quite sure what's going on, and you think I should know how to do this, but no one's ever taught you how to do it. So don't be afraid to ask because people can die if we do things incorrectly. So why do we actually transfuse people? Well, usually because we've got a patient where we perceive a need, something we think we could correct transiently with blood transfusion. Patients with thalassemia, for example, are currently mostly for thalassemia major are looking at a lifetime of transfusion support, but there's a lot of research to try and improve this situation and provide alternatives by treating the underlying condition. Then we've got someone like us, a doctor, saying, look, we think that this product might help the patient. Some of you might know Andrew Davidson, who's an anaesthetist at the Children's Hospital here in Melbourne. I show this picture of Andrew because he was the best man at my wedding a long time ago. He and my husband were medical students together, and it's good to embarrass him on a national platform. And behind all of that, there are teams of people, whether at the blood service, collecting blood, testing it, or in your hospital, like on here on the right, doing the cross-matching, making sure the inventory is available, and getting the blood out the door when you think you need it. So I know we said we've moved from what products do we talk about to how do we transfuse people, but I think it is very important for you to be at least passingly familiar with products that are available. And we're not going to spend an enormous amount of time on that tonight, although we can talk about it more if people would like, but really just to think in broad concepts. So there are allogeneic blood components or homologous blood components donated by someone, a volunteer in our country, for someone else who is not related to them, they don't know. And this could be done by whole blood donation, where the blood products are separated into their components, or by apheresis, where we're collecting platelets or plasma. So red cells, platelets, plasma, cryoprecipitate, usually separated from whole blood or collected by apheresis. Fractionated plasma products. So if you're interested in hearing more about how plasma products are made, then CSL, who is our national fractionator, but as you also know, a huge international company, has quite a good video. It's from one of their North American sites, but you still get the picture, and the basic principles are the same. But these plasma products, they come in little vials. They're not red or yellow. People often forget that these are blood products and they need the same care and attention in terms of traceability, making sure we know who got the product and where it came from and which batch it was. So albumin, various coagulation factors, and immunoglobulins would be some of the most common ones. And these can either be used as prevention, so RHD, immunoglobulin, to try and prevent hemolytic disease of the fetus and newborn from RHD alloimmunization, tetanus immunoglobulin, intravenous immunoglobulin, or subcutaneous immunoglobulin. There's a wide range of products. Historically, we've used a lot of autologous blood components. People thought, especially in the HIV/AIDS era, that these would be safer. Surely if I give it for myself, it will be better. Well, maybe, but this is really not the reality now. And those products are also susceptible to things like bacterial contamination when they're stored. We do use a lot of intraoperative cell salvage, so collecting the patient's own blood, washing it, filtering it, reinfusing it. That's almost an unlimited supply if you start the cell salvage early enough. We might, say in the orthopedic or general surgery setting, collect blood shed from wounds. You'll often see those things hanging off the side of the bed when you go to see the patient after surgery. Historically, there was a big vogue for pre-donating a person's own whole blood or red cells. We rarely do that now, except for patients who have rare blood groups or multiple red cell antibodies, such that it might be difficult to find compatible blood for them. And that's really a very, very limited circumstance. And then there are all sorts of other weird and wonderful things that we can collect from a person and reinfuse or apply topically. Various platelet gels that the sports medicine people really like for tendon injuries and other things. You might know that the Therapeutic Goods Administration that oversees blood products in Australia has recently issued some much more stringent requirements for autologous blood components, including some of these things that practitioners can make in a small centrifuge in their back room. But some of these can go badly or they can go well. So there are lots of caveats about their use, including whether the evidence base actually supports their benefit. In Australia, the National Blood Authority is the government agency that oversees on behalf of all governments and coordinates contracts to have blood available so that we can order it for our patients. And I mentioned before what a huge amount of money that is. And if you're interested, you can look up, there are long, long lists. Here's just a tiny fraction for some fractionated products, both Australian made and imported. And if you look on the right side, you can see hundreds and thousands of dollars even per vial of some of these products. So do not drop any on the floor. Reminder that if these are not used, they must be very promptly returned to the hospital blood bank or occasionally to the pharmacy if that's where they're issued. But this is enormous cost to the community. So we have to use these things wisely. And some of them are a bit boutique and are not the kinds of things that you would be prescribing as junior doctors without support from specialists. I mentioned before how we get some of these components. On the right, you can see a blood donor with his or her arm out attached to an apheresis machine, where their whole blood goes into the machine, is centrifuged, and then the component that's being collected, whether that's platelets or plasma, is collected into that bag, and the rest is returned to the donor. So they don't lose red cells, for example, if they're donating platelets or plasma. So that can be a very efficient way to collect large volumes of platelets and plasma from a single donor at a single sitting without making them anemic, for example. And it's one of the ways, or it's the main way, we're collecting at the moment convalescent plasma for COVID as part of the trials, which we're leading from Monash with the support of the Red Cross and others. On the left is a sedimented unit of whole blood. So you can see at the bottom, the red cells, which are more dense and have fallen to the bottom, the plasma at the top, that looks a bit lipemic, doesn't it? And then in the middle, this sort of white variegated little interface, which is white cells and platelets. And that's where after you can take the red cells out the bottom in that machine, which has got some tubing coming out the bottom. You can take the plasma off the top, and then you can separate the platelets out from that to make pools of platelets. And in Australia, 4 donations will be pooled into 1 adult platelet dose. So you might hear people talking about pooled platelets, which would be from 4 donors, or apheresis platelets, which would be from 1 donor. And there are all sorts of changes and improvements in the manufacturing technology of these, which you don't really need to concern yourselves with too much, but just bear in mind that there are differences in how these products are collected and made, and they can be important differences for the patient. So if you don't know what to do, then you should ask. So with these red cells that we can make, why would we transfuse them? Well, the only reason is to treat symptomatic anemia, which can't be managed without it. So for example, in major acute bleeding, person hosing on the floor from gastrointestinal hemorrhage, trauma, obstetric bleeding, that kind of thing. For patients who've got bone marrow failure, either because of the underlying disease, myelodysplasia, aplastic anemia, something like that, or treatment with chemotherapy or transplant, where the patient is not going to be able to make enough red cells of their own fast enough to keep up with what they need. Or in acute hemolysis, where the patient is knocking off their red cells and their hemoglobin is falling too fast for them to keep up, such that they might develop cardiac compromise. Now, there are lots of situations that are not as extreme as this, and it's very important that we don't simply transfuse for a low hemoglobin alone, or for a patient with stable, uncomplicated anemia, which can be managed with other therapy. So in my hospital, I'm sure in your hospitals too, we get a lot of people sent in by their GPs who are, oh, that hemoglobin is low, maybe from menorrhagia or something like that. Usually this did not happen today or even this week. It might have been something that's been developing for weeks or even months. Most of those people say who are iron deficient, they need iron, whether oral iron or IV iron. But all too often, those people are transfused, which puts them at risk of all the complications of transfusion. But usually it actually takes longer to give somebody a blood transfusion than to give them an iron transfusion. You can do that in 15 minutes these days. You don't need to send off a cross match and get blood and all that kind of stuff. But you do need to have some iron studies sent to the lab so that we can see whether the patient, what's the cause of this person's anemia. So just transfusing for a low hemoglobin is really not okay. Anemia is a manifestation, it's not the diagnosis. It doesn't tell us what the cause of this problem is and how we should treat it. There are guidance documents, national patient blood management guidelines, which focus on different clinical scenarios, one of which, the first one was critical bleeding and massive transfusion. These were published between 2011 and more recently, and there's a cycle of review that's underway, but these are all available from the National Blood Authority's website, and you can download them and look at them. I should mention that the evidence base for many of the recommendations or practice points here is very, very thin. So there's heaps of work to do in improving the evidence base for our transfusion practice. So if people are interested in further study, we can definitely find you a project. So I thought I would weave in a few short cases, and it's not the ideal scenario that we're not in the room together where I can say, okay, you in the back who's asleep, that kind of thing, like people did when I was a medical student. But let's say we've got an older lady who is coming up for elective hip replacement, and she comes into the pre-admission clinic and her blood counts come back showing a hemoglobin of 98. So what to do next? Well, this lady's anemic, isn't she? Her hemoglobin, depending on your reference range in your lab, might be 120, 125 and above for a woman. Should we order this lady a couple of red cells to top her up before her transfusion? I can't see all of you on my screen, otherwise I can't see my own slides, but you probably know that I'm going to say, no, don't transfuse her. So if we use the perioperative practice guidelines, this may be a bit small to see unless you've got a really big screen, but you can see here that there's some guidance for us on how to manage. So is the person anemic? No, we'll just maybe check their ferritin to make sure they're not going to run out. But if they are anemic, is this person iron deficient? Do they have evidence of inflammation, for example, an elevated C-reactive protein? What other investigation might be required, and can we treat it? And how long have we got before the surgery so that we can take action? So this is where having the patient's GP involved in pre-surgical assessment is so important, rather than, oh, congratulations, your surgery is next week. We should do something about that. Now in Australia, because of waiting list times, we've often got weeks to months to identify and do something about this. So this is where, whether you're in general practice or in hospital-based practice, you can really play an important role in identifying and managing anemia. So platelets are another commonly transfused product, and we use these to treat or prevent bleeding when the platelet count is very low, and or if the platelets are dysfunctional, such that we think that that dysfunction is contributing to the bleeding. So we know that about 2/3 of platelets are actually given to prevent bleeding in haematology oncology patients with low platelet counts, so either from their disease or after chemo or transplant. That's a huge amount. That makes it very difficult to provide platelets, which only have a 5-day shelf life, all around the country every day of the week. We know that some conditions, uremia, all sorts of other things, can cause platelet dysfunction. So can many drugs and many over-the-counter and other medications and supplements. So we have to think what might be the cause of which would really justify platelet transfusion, not just a low platelet count. But for example, in critical bleeding, when the patient is losing more platelets than they can send out of where they've been hiding in the spleen or out of their bone marrow, they're all going to be on the floor or down the sucker. We might give platelets as part of a massive transfusion protocol. Or if the patient's got acute DIC and they're being consumed, this might be a reason to give platelets very cautiously, but we always worry about this so-called fueling the fire in DIC. If you give more platelets, and does that just give an opportunity to make more microthrombi? In patients with bone marrow failure, such as haematology oncology, as I've mentioned, these patients use the most platelets. A lot of this is not very evidence-based. It's intuitive. The platelet count is low, we should give them some, might prevent them from bleeding. But actually the evidence for that is not strong. And we know that many people in this scenario, even if we give them a platelet transfusion, then from studies that we and others have done, more than 40% of people will still have some kind of bleeding. So platelet transfusions of themselves are not maybe the only answer. So don't give platelet transfusions just if the platelet count is low, especially if the patient is not bleeding. Don't give platelet transfusions for immune destruction, such as in ITP, or because they will be destroyed as fast as the patient's own platelets. Only give them for an emergency if the patient with ITP has got, intracerebral hemorrhage or something like that. And in chronic DIC without bleeding, we don't transfuse platelets. So plasma or fresh frozen plasma, we might use that to try and treat or prevent bleeding in a coagulopathy, and where specific therapy is not available for that patient. We also do use it in therapeutic plasma exchange, which we won't spend any time on tonight given the time, but we can talk about it more. It's a pretty specialized scenario. So we might give plasma as part of a massive transfusion protocol if the patient is bleeding and coagulopathic. And there it's very important to try and keep up and not let the patient get too coagulopathic before you take action. If the patient has acute bleeding, but there might not be any specific therapy available, reversing their anticoagulants with vitamin K if they're on warfarin, using prothrombin X, which is made from plasma and contains factors 2, 7, 9, and 10. But wherever we can, we should use what specific factor replacement is required. And simply having an abnormality of a laboratory result without bleeding, we might not need to correct that at all. So you should consult Haematology, because we're very friendly and we're here to help. And we love to hear about people who would like to have an idea of correcting minimally abnormal laboratory tests. So to use that as an example, here's a middle-aged man with chronic liver disease, ascites, and for symptomatic relief of that, he's going to have an acidic tap. His INR is 1.5. Should we give this man some FFP to correct his INR of 1.5? No, I hear you say from all around the country. So we know that FFP is wildly, absolutely wildly overprescribed. You're really, with an INR of 1.5 or less, you are on a hiding to nothing of trying to correct this to normal. And in fact, you are probably just as likely to drown the patient in some FFP as usefully correct their INR. So we can talk about this more at the end if people would like to talk more, but there is a lot of evidence that many plasma transfusions are inappropriate and in fact put the patient at risk of complications. So cryoprecipitate is a slightly mysterious blood component that when I was in your shoes, I had no idea what it was. But it really, in our country, we use it as a source of fibrinogen. And it's prepared from plasma and comes in small volumes. So we freeze the plasma, then we thaw it out at low temperature, and the fibrinogen and other cryoproteins precipitate, which is where we get the name cryoprecipitate. And we can use that as a concentrated source of fibrinogen. So we could give in you know, a few mils, the same amount of fibrinogen as in a whole unit of FFP. And we generally use it in the massive transfusion setting or for patients with congenital or acquired dysfibrinogenemia who are bleeding or at risk of bleeding. Now, in the olden days, olden days, even before I was a medical student, we used to use this for the treatment of haemophilia because it also contains lots of factor VIII and factor 13, fibronectin, all sorts of other things that can help your blood clot. And in some countries where there is not access to either plasma-derived or recombinant coagulation factor concentrates, it is still used, but it's extremely rare to use it here in Australia for such a purpose, and only under the guidance of a super specialised haemophilia clinic. When we are transfusing cryoprecipitate, we are trying to keep the fibrinogen level above 1, or in obstetrics above 1.5, because fibrinogen levels normally rise in pregnancy, and so a fibrinogen level of 1, which would be acceptable for most settings, would be low in obstetrics. And so for that reason, we need to keep this in mind. And people often forget until it's a bit late and the person's becoming more coagulopathic to give fibrinogen, so we try and give it early in the piece of major hemorrhage. So I haven't spent a lot of time on those products, and we probably don't need to much more, but happy to take questions, and there is information available. But I'd really like to turn a bit more to how we make decisions about transfusion, because this will be important work that you do over the next few years. So this concept of patient blood management. So this is a definition, there are many similar definitions. This one's from the International Society of Blood Transfusion. And it talks about PBM, patient blood management, as an evidence-based, multidisciplinary approach aimed at optimizing the care of patients who might need transfusion, putting the patient at the heart of decisions made around this topic, promoting appropriate use of blood and blood components, and the timely use of alternatives where these are available. So this includes application of appropriate clinical indications, minimizing blood loss, optimizing the patient's own red cell mass, so preventing anemia, treating it. And it can reduce the need for allogeneic blood transfusions donated by volunteers, and it can reduce healthcare costs in some settings, while ensuring that blood components are actually available for the patients who really need them. So rather than topping up unnecessarily ladies with mild anemia when we could be treating them with some other thing, we could make sure that the products that are needed for thalassemia patients or other patients are really there when we need them. And so now this is really articulating what we consider international best practice in transfusion medicine. And so you don't have to call it PBM, but you'll commonly hear it heard by that name. And so some people have summarized this into a kind of 3 pillars model. This is very widely used. It's a bit focused on the elective surgical settings, such as you can see down the side here, preoperative, intraoperative, postoperative, and things that we can do in different domains, optimizing the patient's own blood supplies, minimizing blood loss, improving tolerance of low counts. We won't go through all of these here. You can read them at your leisure. But it is quite a useful, if a bit simplistic way, maybe, to think about how to summarize these activities. And of course, we mentioned multidisciplinary approach on the previous page. So some of these might be undertaken by the anaesthetist or the surgeon or somebody in ICU or a haematologist or the GP, for example. They're not all done by the same people, and the patient should be an active participant in how to approach this. But it's very important that we are clear that PBM is more than just avoiding red cell transfusion, and it's not just in the surgical setting. In fact, it's much more global than that. And very importantly, PBM is not anti-transfusion and definitely not withholding transfusion from someone who needs it. In many cases, yes, it might result in fewer transfusions overall. and hospital CEOs and government departments, they're very, very interested if we use fewer blood components because that might save money. And that's often how these things are measured in terms of benefit. And we're all wanting to save money to the community, but that's not the only consideration. In fact, some people might need more or different types of transfusion support. And our job is about understanding what they need and then coordinating support as they're treating doctors and working with the hospital blood bank and others to provide the right products if and when they need them. So our role is really, and our goal is really, to individualize therapy. So to have a PBM management plan for this patient in this circumstance and with the patient's active participation. So we're all about personalized medicine. So I like to think that this is really precision transfusion medicine, not what would, you know, the average orthopedic surgeon, surgery patient need, or the average so-and-so, or 100 people, what does this person need? And how can we make sure they get what they need? If anything, they might not need any transfusion at all. But the only way we might achieve that is by planning ahead and putting these measures in place. So there are lots of other ways that we think about, you know, precision transfusion medicine. For those of you who are interested, genotyping has really revolutionized many aspects of our work in transfusion, along with other areas of medicine. This was a nice review that came out last year about different ways that we use genotyping in transfusion medicine, whether it's blood typing, or for patients or donors, or typing, for example, of a fetus antenatally to identify whether that fetus might have inherited certain antigens from the mother or father, and be it particularly in this case from the father, and be at risk for hemolytic disease of the fetus and newborn, or for example down here, fetal or neonatal alloimmune thrombocytopenia, which is the platelet equivalent of red cell hemolytic disease of the fetus and newborn. And then there are lots of ways we can provide more targeted therapies, for example, accurate Rh antigen matching for patients with sickle cell disease, many of whom have a huge diversity in Rh system antigens. And this paper just came out a few weeks ago from an international collaboration developing a universal platform for blood donor genotyping, which is very, very efficient, because you only need to genotype someone once and you've got this enormous information about the potential compatibilities, but not just for patients who might receive their blood, but also, for example, if we could identify things like HLA types that might make donors more susceptible to various conditions, or protection against iron deficiency, you know, then we can develop individual donation plans for people rather than having a one-size-fits-all. So I've mentioned several times that we need better evidence to guide our practice, and even though we've got all these great technologies and new techniques to help us have more information, we still need to try and make a decision about the person in front of us. So on the right, this little diagram from the Cochrane collaboration, I like it because it says this is how we make evidence-based medicine decisions. We take the best external evidence, we put that along with our individual clinical expertise or expertise from others, if that's not our area of expertise. We incorporate the patient's values and expectations, and that becomes evidence-based medicine. But in transfusion, there are a lot of things we've done really historically for many decades with some holes that you could drive a truck through in terms of gaps in the evidence. So this is really a wonderful opportunity to say, look, how can we improve the design of clinical trials in transfusion medicine? So a lot of the time, until very recently, we've used pretty simple things like, did people get more or less numbers of red cells, or did their hemoglobin or platelet count go up? But we've not asked ourselves, is this person able to go out and do their shopping because they are less anemic and more independent? Can they walk up and down stairs? Do they get breathless? What's important to the patients? So the use of patient-reported outcomes and health-related quality of life is really now central to transfusion medicine trials, but also, of course, across medicine more broadly. We also need to understand what are the different trade-offs that we're making when making decisions about transfusing or not transfusing somebody, and considering new therapies that might be becoming available. We need to compare them with standard of care before we just adopt them holus bolus. So a couple of years ago, we convened an international consensus conference on patient blood management. And this was a really great opportunity to get hundreds, literally hundreds of people from around the world, surgeons, anaesthetists, haematologists, nurses, scientists, everybody, to think about different aspects of a red cell transfusion and how we could improve our practice. And it was also a really nice way, I thought, of presenting the data in these sort of flower diagrams, where we were looking at different clinical scenarios and looking at the strength of evidence. So a deep red here, a bright red here, meant we had evidence to make a strong recommendation. We didn't have any high quality evidence. We only had some strong recommendations based on moderate quality evidence, you know, 1 or 2 trials up here in the top for cardiac surgery and critical care patients. For hip fracture with cardiovascular disease, there's like 1 trial, but it was a well-conducted randomized controlled trial. And then everything after that is pretty weak evidence, as you can see here. In fact, a lot of it is very, very limited. So great opportunities for research in the future. So turning a little bit to someone very famous in blood transfusion. So you might know that Karl Landsteiner discovered the ABO blood groups in 1901. And World Blood Donor Day is celebrated on his birthday in June. And he went on to win the Nobel Prize in 1930. And when he was giving his Nobel Prize speech, he said, and this is in 1930, all in all, the results of blood transfusions are already highly satisfactory. And we have reason to hope that a thorough study of cases with undesirable after effects will help us to assess the significance of the suspected causes and perhaps reveal unknown causes, and thus finally virtually eliminate the slight risks which transfusion still involves. Well, I think that makes him maybe an incurable optimist, or maybe a bit naive, but also he, in that regard, I think he is the founder of haemovigilance, which we'll talk about now for a few minutes. So what is haemovigilance? Well, it's a set of surveillance procedures covering the whole transfusion chain, from the collection of blood and components to the follow-up of recipients, to try and collect and assess information on unexpected or undesirable effects resulting from the use of blood transfusion, and to prevent their occurrence or recurrence. And so I like to have some way of categorizing adverse events. These can be either clinical reactions, and you can think of these as immune or non-immune mediated, immediate or delayed, infectious or non-infectious. It's a bit simplistic, but it is quite helpful when you're running through a list in your mind. And then there are incidents, so procedural or clerical incidents, for example, wrong blood in tube events, where the product, the sample was collected from the wrong patient, but labeled with the right identifiers, or collected from the right patient, but labeled with the wrong identifiers. And of course, when these happen, there are many more ones that are near misses. And then other things like blood wastage, that is in itself an unwanted consequence of blood transfusion. And some of these adverse events can be fatal. So we should only transfuse people if there's a clear benefit. We should monitor the patient carefully, and we should make sure that the patient understands why we're recommending a transfusion. So if you're taking care of a patient when they look like they might be having a transfusion reaction, You should pause the transfusion. Don't take out the IV. Keep it in, but because we might need it again. Do an immediate assessment at the bedside. Do a documentation check. Make sure we haven't got the wrong patient or the wrong unit of blood. And then call for someone to help you. This is it can be a very serious situation. You might need to make a MET call if you're by yourself. And then we'll contact the haematology team in the transfusion lab and help you get some samples and manage the patient. So this is not an Australian case, but it could have been, and there are certainly cases like this all around the world every year. And a patient died after being given the wrong type of blood. So the patient was group O and he received group AB red cells and he died. And I like this story, not a sad story, of course, but it actually reminds us, the headline is, "Nurse Gets Suspended Sentence Over Fatal Blood Mix-Up." There are really two people here who have suffered an adverse outcome. It was really a mistake or probably a series of mistakes, as you can see here. But also, are we providing people with the right training and environment in which to work so that these mistakes don't happen? So the UK has probably one of the best haemovigilance programs in the world, and you can read their annual report. It gets published every year in July. Anyone can have a look at it. And you can see here, these are some data from when they started collecting information in 1996 up to this past year. And the graph is organized in three sections. The bottom section, which are adverse incidents due to mistakes, which is the vast majority of all cases. So people like us giving an incorrect blood component to someone, handling and storage errors, delayed and avoidable transfusions. The middle section is sort of biological things that might possibly or probably have been preventable. And then at the top, there are some things that maybe couldn't have been foreseen and are unpredictable. But clearly, that bottom section is a huge opportunity for improvement, as probably people like to say. So why is it a problem to give people the wrong blood? Well, maybe you could cause an ABO incompatible blood transfusion. For reasons of time, we won't go through all of what antigens are on the surface and what antibodies are in the plasma, but you do need to know this. It's very important. And if you give somebody an incompatible blood transfusion, this might be the color of their plasma or urine with acute hemolysis intravascularly. And if you put the for example, red cells that are group A with anti-A in a little tile in the lab, you can see that agglutination that's caused by pre-existing, pre-formed IgM antibodies that can cause immediate intravascular hemolysis. So this is not good for your patient, and it's certainly not good for you. So in Victoria, we have a haemovigilance program called STIR, or Serious Transfusion Incident Reporting, and it links in with many other aspects of our transfusion practice improvement, which we won't go into for reasons of time. But I'll just describe one case that was an example. There are lots of others. An incorrect blood component transfused, and you can see how this might happen so easily. So a patient was in the emergency department and they were moved from the resuscitation area to another area. But a sample tube that had been collected from them, which had not been labeled yet, was left behind. And a new patient was put into this emergency cubicle in resus. And the staff thought that this tube was from the new patient, and they labeled it with the patient's label. And the sample was sent to the lab, and based on the results, the transfusion lab issued 4 units of group A red cells, 2 of which were transfused to the patient in the emergency department and 2 issued for transfer to a larger hospital. And on arrival at the large central hospital, the patient was in fact found to be group O, not group A. So there were lots of problems here with this case. Firstly, the staff did not comply with identifying the patient prior to transfusion, but also with labeling the sample at the bedside and before leaving the patient. When the lab got a discrepancy between a previous and the current hemoglobin on that patient, and the staff had not signed the collector's declaration, which is the paperwork that goes along with that, they still accepted and processed the sample when they should have rejected it. And the wording of the report said that the lab was urged to continue due to the deterioration of the patient. To me, that sounds like someone was shouting at them from the emergency department saying, just give me the blood because this patient is bleeding or something like that. But then in an emergency, we can always provide emergency blood group O uncross-matched red cells rather than group specific, group A blood in this case, for this patient. So this might have been avoided. So you can see how these holes in the Swiss cheese can add up in terms of errors and patients can come to harm. Now, in the interest of time, I've got other slides, but I'm just gonna skip over those and go right to the end. If that's all right, Gabriel, just finish with a few resources that people might find helpful.
That would be great for those who want to have resources.
Great. So just as we think about what the future might hold, I hope I haven't terrified you too much thinking about blood transfusion, but there are lots of exciting things in the future. So in the very near future, for example, will we still need to do antigen and antibody testing in the test tube or equivalent? Maybe we'll be able to do molecular typing upfront on many more donors and patients, and that might save us some time and give more accurate information. There are a lot of new blood substitutes and other therapies that are likely to become available, but even with the ones that we already have, we need to learn how to use them better. And cellular therapies may be options for more patients, and theranostics or sort of diagnostic things that are also therapeutic might be very valuable. I'm sure that we'll have a lot better treatment for some of the underlying conditions, you know, thalassemia, MDS, sickle cell disease that we mentioned today. We'll have clinical trials with proper patient outcomes, and we'll definitely have a better understanding of the biology of blood cells, because these blood groups we're talking about, they're not just on the surface of red cells, they're histo blood groups, they're on endothelial cells and all sorts of other cells in the body. So God just didn't put them there to amuse people like me and others. They've got some biological function, but in many cases we don't know what they are. So some words of advice: take transfusion seriously. It can save people's lives, but it can kill people if done incorrectly. Ask for help when you need it. Do not be shy or embarrassed that you don't know what to do. This is not intuitive, and nobody should expect you to know how to do this. Get involved, go and visit your hospital blood bank, find out where it is, get to know the scientists, get to know the transfusion nurse in your hospital, get to know the haematology registrars. These people can be lifesavers for you and your patient. And if you can, be a blood donor. Not everyone can be a blood donor, but lots of people can. So there's some great resources from the Red Cross on their website, including things about how to administer blood, information about the products, information about current risk estimates in Australia for these infectious agents. And you can see here that they're all either extremely uncommon or extremely uncommon. And these are risk estimates based on modelling. They're not actual cases. They're so uncommon they need to be modelled. We need to think about any special types of red cells or other modifications that our patients might need, how we store them, how we handle them. There are all these different mysterious washed and irradiated and other things. They're not very mysterious, and you can quickly learn what they are. There are some great online short courses to do from Blood Safe eLearning Australia, which was started in South Australia, but is a national program. Anybody can register for free and do these. All sorts of fantastic topics, which are really good groundwork to do as a medical student and before you start more clinical practice. I won't go through them all in detail. But there are other resources, understanding pathology tests, including from the College of Pathologists. There's an Australian New Zealand Society of Blood Transfusion, which has an annual meeting, although not this year, and has grants and awards that you can apply for. There's the International Society of Blood Transfusion. If you're interested in transfusion, there's a student rate and there are scholarships to go to congresses. And this year the Congress will be held virtually in December, and you'd be welcome to join in. And there are lots of other materials from the ISBT. Gabriel just asked if I'd say a few words about transfusion medicine as a career. Well, it's a great interest to many people around the world. There's all different types of careers that you can pursue in transfusion medicine. As I said, everything from molecular genetics to public health, and people in transfusion are really, really nice. And I think a lot of that comes from the fact that we are dealing with blood donors who are volunteers and we're trying to take care of patients. This is our research unit, if you're interested in hearing more about what we do. And I mentioned we're involved in the convalescent plasma trials. This is my colleague Zoe McQuilton doing an interview about those. And we have a lot of other research going on. So if you'd like to hear more, please get in touch, or I'm happy to stay around and take a few questions if people would like that. Thank you.
Thanks, Erica, for the amazing presentation. It was really interesting, and I think it's really interesting how important haemovigilance is, but how, I guess, unknown it was to me before going to this seminar. I think it's something to be a bit neglected in the teaching in medical school. We might just move on to some questions. So I've been getting them off Pigeonhole. So for the audience, if you want to go into Pigeonhole and upvote questions you're interested in, or post questions that you want to see answered. So the first question is there a place for stem cell therapy for production of red blood cells in the future?
Yes, in the future, but already now. So some blood services have really invested in this. The UK, NHS Blood and Transplant, for example. This is, of course, of great interest because if we could, grow these in a lab, then we could design the red cells we wanted. So we could, for example, produce almost unlimited supplies of Group O red cells without some of these other pesky antigens on the surface. So they would be very useful for emergencies, and they would be the kinds of things that may be helpful not just in the civilian setting, but also in the military setting, where you might not be having time to do all the cross-matching and those kinds of things. So those are already a reality. The main issue is about scaling up production, which is the focus of a lot of work, as well as tweaking. But the principle is already well established and in place.
Great, thank you. The next question is there a difference in quality between young donors and old donors?
Oh, good question. So the answer is not really, not for practical purposes. So there's been a lot of, in the sort of weird and wonderful branch of the popular press about, giving plasma infusions and red cell infusions from young donors as if this would be rejuvenating. The answer is that is not the case. We know also that, for example, some young donors, they might have more marginal iron stores, young women in particular, pre-menopausal women, they often have fairly marginal iron stores. So we need to make sure that we're not taking advantage of people, making them iron deficient or any other consequences as far as we can. But their product quality, not particularly an issue for practical purposes. Yeah.
Okay, very interesting. Um, do all laboratories perform cross-matching using both methods of immediate spin and indirect Coombs tests? Wouldn't this be impractical in an acute situation?
Yeah, good question. So the immediate spin is really basically you put the plasma and the cells together and you see if they agglutinate, and that is really just a blood group compatibility check for a sort of IgM without any incubation. It can be a very, very important safety check, and but at the same time, there are antibodies, IgG antibodies, where incubation at 37 degrees is helpful to detect these. So we can usually do a blood group and an antibody screen in under 30 minutes. You can do a blood group in very few minutes. With the types of gel card systems we have, or we don't really use test tubes anymore, and with laboratory automation, this is now much faster than before. But one thing to remember is that in a real emergency, patient is bleeding to death, then issuing a Group O uncross-matched red cells can be used for pretty much anybody, Group O RHD negative red cells, and they can be available without waiting for that cross-match. We still need to do the cross-match, but you don't always have to wait for the results in a life-threatening emergency. So that's a good message to remember.
Thank you. And we can do some more questions if you want, Erica Wood, or we can wrap it up here.
I've got time. Sure, no problem.
Okay, great. So how do you distinguish between febrile hemolytic transfusion reaction versus a febrile non-hemolytic transfusion reaction clinically?
That's a very good question. So at the time, at the bedside, you might not be sure. So in a febrile non-hemolytic transfusion reaction, which used to be much more common before we had routine pre-storage leukodepletion, so removal of most white cells from the products by the Red Cross, which was the situation when I was in your situation. We used to have a lot more febrile non-hemolytic transfusion reactions, and patients would get fevers, rigors, chills, and they would be rigoring away. And these were particularly common after platelet transfusions because platelets are stored at room temperature, 20 to 24 degrees C. And those white cells used to be able to produce lots of cytokines during storage, and then you'd infuse them into the patient and they would get a nice rigor. That's what cytokines do, isn't it? So immediately, you cannot always tell. So if there are any concerning signs, for example, a very high fever, 40 degrees, if the patient is hemodynamically unstable, if they are having mental state changes or other things, they're starting to develop acute DIC, these kinds of things, then, with oozing from their IV sites and other things, that is a true medical emergency and you need help ASAP. Of course, those things are uncommon, but when they do occur, they can be life-threatening or even fatal. So if the patient looks okay, if the patient does not have any of those other concerning features, particularly hemodynamic instability, then it may just be a simple febrile non-hemolytic transfusion reaction. One of the most important things while you are taking the patient's pulse, checking your own pulse and rechecking the temperature, is to make sure that the unit of blood was intended for that person. So do a clerical check at the bedside, because if you identify that this is not the right patient or this is not the right unit of blood product, then you should really have a high index of suspicion. But the main message is go to the patient's bedside, do a careful clinical examination, don't leave the person unattended, monitor them closely and call for help until or unless you're sure that this is not developing into something more serious. really you can only make those decisions after the event. You can say that turned out to be not too bad. The other thing to remember too in a patient with a high fever with rigors and chills is to, I skipped over this because of time, just think of whether this could be bacterial contamination of the unit. And that sometimes presents exactly the same way: high fever, hemodynamic collapse, and an urgent gram stain of the remaining product by the lab can confirm a diagnosis if that's the case. It can't rule it out if it's negative, but it can be very important to know. So stop the transfusion, examine the patient, send the samples to the lab, do the clerical check.
We might just do one more question.
Sure.
In anemic patients with heart failure, is red blood cells usually given with furosemide?
The answer is they often are. The optimal approach to pre-post transfusion diuretics is really not established. If you have a patient with heart failure or a patient who's already got a volume overload issue, then it may be appropriate to give small dose of diuretics prior to starting the transfusion. Remember that unless the patient has a catheter, they will be wanting to try and get up and go to the toilet, and that makes it very difficult to monitor them closely. And people have had transfusion reactions in the bathroom because people were being, aggressively diuresed. So if you think that the patient's status is very marginal, then yes, it might be appropriate to give a small dose of diuretics either in advance or at the time of the transfusion. Otherwise, you could monitor them carefully and give one a schedule 1 for post. But the main thing here is really to make sure the patients are carefully monitored, not just by the nurses, but by the medical staff as well.
Awesome, thank you. And thank you so much for coming tonight and doing this presentation with us. It's been really interesting, and it's been, I think, incredibly valuable for the audience as well. I just want to thank the audience as well for coming tonight and watching this seminar. It's been great to have you all here. We might leave it there.
Thank you.
Thanks, everyone.
Thanks, everyone. Bye-bye.